Next speaker is Professor Lipika Goyal. She is from Internal Medicine Division of Oncology, Massachusetts General Hospital Cancer Center. The topic of her presentation is Precision Medicine on the Horizon for Cholangiocarcinoma. Welcome, Goyal.
Thank you. I want to start by thanking the organizing committee for having me here. It's really an honor to speak among so many esteemed colleagues. So I'm going to be talking about refractory disease and molecular profiling in cholangiocarcinoma. So we all know about personalized cancer therapy. You take a homogeneous group of patients. They all look gray. They all look the same. And then you can do molecular profiling, and you can figure out if there are markers that are predictive of drug sensitivity and resistance. This is from the MD Anderson website. They're leaders in precision medicine. And what we have seen is that there have been many examples of precision medicine being successful in oncology. And so it all started with imatinib in CML. And then we also have trastuzumab, erlotinib, crizotinib, larotrectinib, so many different personalized medicine options in cancer these days. And why does personalized medicine work? The idea behind it is that tumor genetic profiling allows drugs to be tailored to specific patient groups. In an ideal setting, you have the potential to offer the right drug to the right patient for the right disease at the right time with the right dosage. And what are the potential benefits? You have improved outcomes for patients. So you can see response rates greater than 50% in some of these trials. You minimize adverse reactions because you're not giving drugs to patients where it's not going to work as often. And you reduce costs of clinical trials because you need fewer patients to show a response when you have a drug that works. And then also we've seen many examples of accelerated FDA approval. The FDA has been wonderful in working with the oncology community to try to get drugs approved in an accelerated fashion before needing randomized phase 3 trials. So how about in cholangiocarcinoma? So personalized medicine in cholangiocarcinoma, it's not yet ready for prime time, but it's getting there. There have been multiple studies in the past of targeted therapies, but they're usually in unselected populations. Most notably, we've tried EGFR inhibitors and VEGF/VEGFR inhibitors, and they have not established benefit in cholangiocarcinoma to date. And we do not have any targeted therapies yet, but some are on the horizon. And that's what the focus of my talk is going to be. So one of the good things about going in the afternoon is that a lot of people have done my work for me. So I've adapted my presentation. I have several slides of things that people have touched on during the day. So I'll just touch on them, but I'll skip several slides just so people don't hear the same thing they heard this morning. So I'll talk a little bit about the genetic landscape. Then I'll focus on targeted therapies in clinical trials. And then I'll talk about acquired resistance. And as Nilo was saying, with immunotherapy, there's so many different categories of immunotherapy. Same with targeted therapy. There's so many different targets that are being explored in cholangiocarcinoma, but I'll mainly focus on 3, FGFR, IDH, and BRAF, and then just touch on the others briefly. So this is, Dr. Shabadi talked about this study already. This was liver fluke versus non-liver fluke in cholangio, so I'm going to just pass by this one. He also talked about this paper in great detail. This is a fantastic collaboration among 10 countries of almost 500 cholangiocarcinomas. But again, he went into a lot of detail here, so I'll skip past it. I will just mention one profiling paper that Dr. Javle led the efforts on, over 500 cases of biliary tract cancer. This is from the Foundation Medicine database. And one of the notable things about this profiling was that over 300 patients had clinical annotation. And this was a collaboration between MD Anderson, UCSF, and Ohio State. And we were able to do some identification of prognosis and also note that FGFR2 mutations and alterations were associated with improved overall survival, younger age, and female sex, and that targeted therapy was associated with a trend towards overall improvement in outcomes. So as we know, there are many different mutations across the 3 different anatomic subtypes. It's a heterogeneous disease. And the key point here is that this is where patient advocacy can make a big difference because patients need to have their tumors profiled, but as Dr. Javle mentioned this morning, only 60% of patients with lung cancer are actually getting profiled, and that's where we have molecularly targeted therapies that are approved. So the Cholangiocarcinoma Foundation has started a Mutations Matter campaign to help educate oncologists and patients to get their tumors profiled. So targeted therapies in clinical trials. So there are 3 different approaches that I've seen that people have taken to studying targeted therapy in an uncommon cancer. When you have a target that has a reasonably high frequency, you can do a target-specific trial. So IDH1 mutations you see in up to 20% of patients, FGFR2 fusions you see in about 10 to 15% of patients. So you have target-specific trials in cholangio for this. And then you can have target-specific all-comer basket trials where you have a cohort. So this is where you have a slightly rarer alteration. So BRAF mutations are seen in about 4 to 5% of patients with intrahepatic cholangiocarcinoma. So there is a basket trial that I'll discuss where there are many different advanced solid tumor types with patients with BRAF mutations, and 1 cohort was biliary. And lastly, umbrella trials. So how do you harness the power of multi-institutional collaboration, and how do you help patients who have more rare subtypes? Basket trials, umbrella trials are one way to do this. So I'll first start with the target-specific cholangio trials. So Dr. Yen spoke about this morning. So the AG120 trial, the response rate for this trial, which is an IDH1 inhibitor, was only around 5%, but the stable disease rate was around 56%. And this was how they built upon moving forward with the phase 3 trial. It was based on the PFS rate. So the progression-free survival at 6 months was 38.5%. So instead of using an overall response rate as their primary endpoint, they actually used a progression-free survival rate as their primary endpoint for their phase 3 trial. And that is right here. So they did a 2-to-1 randomization of AG120 versus placebo. And their primary endpoint was PFS, and they were looking for a hazard ratio of 0.5. And this was a trial that accrued in record time. In less than 2 years, they accrued more than 180 patients. And it was a placebo-controlled trial with a 2-to-1 randomization. So we're all excited about getting this data, hopefully later this year. And then this is a phase 2 trial for patients with FGFR alterations. It's a drug called BGJ398. And this was a trial of around 60 patients with mostly intrahepatic cholangiocarcinoma, some extrahepatic cholangiocarcinoma, and 75% of them had FGFR2 fusions. And the response rate was 19%. And this is unprecedented because in second-line chemotherapy for cholangiocarcinoma, if you look at historical controls, it's around 5 to 10%. So we were very encouraged by this. And then there have been a series of other companies that have looked at their FGFR inhibitor in patients with FGFR2 fusions, and you see that overall the response rate is somewhere between 20 and 30% with all of these different drugs, and they're all small molecule tyrosine kinase inhibitors that are FGFR inhibitors. So just to share one patient story, this is a patient of Professor Andrew Zhu at Mass General. She's a 53-year-old Chinese woman who had an FGFR2 fusion positive metastatic intrahepatic cholangiocarcinoma. And when she came to see Professor Zhu, she was coughing quite a bit and had a poor quality of life. And within 2 months of being on an FGFR inhibitor, TAS120, she had a minus 32% response, and all her lung lesions had shrunk considerably. And actually, within a week of being on the drug, she had told Professor Zhu that she was feeling a lot better and her cough had significantly improved, so she felt the drug was working. And we're seeing this across all the FGFR inhibitors. We're seeing significant tumor shrinkage, and we're seeing people are having an improved quality of life in some cases, and certainly we're seeing people be able to have some of their life events more often. I've had several patients be able to see their grandchildren be born, or have people go to their son's wedding or their daughter's wedding. And so we're excited for this class of drugs in general for what it's been able to do. So then the next one is for the BRAF inhibitors. So this was the ROAR trial. As I mentioned, it was a phase 2 trial with many different patients with BRAF V600E mutant advanced solid tumors. Biliary tract cancers was one of the cohorts. They enrolled about 35 patients with biliary tract cancer. These patients got a combination of dabrafenib and trametinib. And what they found was the response rate was 42% by investigator assessment. The PFS was 9.2 months, and the median OS was 11.7 months. Again, given the historical controls, this was really impressive data, so we're excited to see where this goes next. And then lastly, the biliary basket trials. There are two to speak about. Dr. Javle spoke about batch this morning. The one thing I would say is, after listening to Dr. Hung's talk this morning, the idea of using metformin and a CTLA-4 inhibitor might be quite exciting. And so in patients that have no actionable alteration, we can maybe consider adding that into batch. And then Dr. Bridgewater is leading the ABC-10 trial, which is a very similar model in the UK. It's going to be patients who get profiled and then are on a series of different arms that are molecularly selected, and again, having an arm for people who don't have an alteration. And so other actionable signatures in cholangiocarcinoma, there is the DNA damage repair mutations, and Dr. Daniel Ahn from the Mayo Clinic and colleagues are going to be opening up a trial of olaparib. HER2 amplifications and mutations are seen in about 5 to 10% of patients with biliary tract cancer, and there are some basket trials that are going on that have biliary cohorts, and then a series of other alterations listed there. So in bile duct cancer, we're hoping in the next 1-2 years we'll have FDA approval of a targeted therapy, but there are several more that hopefully will come down the pathway. And then lastly, I'll just talk a little bit about acquired resistance to IDH inhibitors and FGFR inhibitors. So there's a famous Canadian hockey player named Wayne Gretzky, and a very famous quote that's used a lot in circles in the US actually is, skate to where the puck is going, not to where it has been. So we're excited that targeted therapy may be approved in the next 1 to 2 years. Thinking ahead, what are the types of resistance people are going to develop to these, and how can we cut them off at the pass? So this was a beautiful paper that just came out of Sloan Kettering, led by Dr. Harding and Dr. Lowry, and it looked at patients who developed resistance to IDH1 and 2 inhibitors. And so it was a paper that had 4 patients in it. 2 had AML, 1 had cholangiocarcinoma, and 1 had myelodysplastic syndrome. So I just focused on the patient who had cholangiocarcinoma, obviously. So this was a 79-year-old woman who had an 8-centimeter tumor, and as you can see, over the course of a year, her tumor shrunk considerably. She had more than 50% tumor shrinkage and was on the therapy for more than a year. And then when they did a tumor biopsy at baseline, she only had an IDH1 mutation. She did not have an IDH2 mutation. And sorry, I can't remember if I mentioned that this patient was on AG120, which is an IDH1 inhibitor. And then at the time of progression, she retained her IDH1 mutation in her tumor biopsy, but then she had a new IDH2 mutation at R172V. And then they did ctDNA analysis, and they found that when she was on AG120, the IDH1 mutation, the allele fraction went down significantly over time. And as you can see, the IDH2 mutation was not present at baseline, but emerged over time. And so they saw isoform switching in all 4 patients. So this is something certainly to look out for. She went on to an IDH2 inhibitor after this, but then unfortunately progressed within 8 weeks. And then going on to FGFR resistance. So, we think about a pyramid of vulnerabilities. So we know that EGFR, ALK, NTRK, c-KIT, BRAF, these are all highly actionable alterations in a variety of different cancers. And we see response rates of 60, 70, 80% for some of them. But then there are middle of the pyramid vulnerabilities, such as PIK3CA, HER2, FGFR, CDK4, which are actionable, but we don't see the same kind of responses. And then there are bottom of the pyramid vulnerabilities, which are holy grails in cancer. If someone can target P10 or P53, certainly that's Nobel Prize worthy because they're very prevalent in cancer, but they're hard to target. And so when you look at the BGJ data, you see that there is a percentage of people that had a response, but why is it that we're only seeing 20 to 25% of patients have a response, and all these people have a little bit of shrinkage, but then they start to grow again? And then while in ALK fusion positive lung cancer, you see with crizotinib response rates of 70 to 80%, and they tend to be more durable. So at MGH, we've put a lot of efforts into trying to understand FGFR resistance. So we have clinical efforts where we have patients on FGFR inhibitors and do serial biopsies and blood draws. We have a rapid autopsy program, which I'll talk about. And then we have laboratory efforts that are led by Nabil Bardisi, Ryan Corcoran, David Ting, and Cyril Bennis. And we are making a lot of models, so cell lines and organoids. And then we're also doing some high-throughput drug screening, and then also doing some ctDNA analysis to follow clones in the blood. And so at baseline, what we do is we do a biopsy on all of our patients, send tissue to Dr. Bardisi's lab to make models, and then we collect blood serially while they're on treatment. And then post-progression, we repeat the same as we do pre-treatment. And then at the time of death, for patients who are willing, we do rapid autopsy. And so I'll briefly talk about some published data that we have on acquired resistance to BGJ, and then some unpublished data that we are hopefully going to put out soon about overcoming FGFR resistance with TAS-120. And so these were 3 patients on the phase 2 trial of BGJ that all had FGFR2 fusion positive cholangiocarcinoma. As you can see, all of them had a 28 to 50% response on BGJ, but then within 4 to 8 months, they all progressed. So we wanted to try to understand why. We thought, FGFR is a tyrosine kinase. We're using a tyrosine kinase inhibitor. The resistance may be similar to what we see in lung cancer with EGFR inhibitors and ALK inhibitors. Maybe these patients will have the gatekeeper, and we just got to figure out a drug that can overcome the gatekeeper. The greatest tragedy of science is the slaying of a beautiful hypothesis with an ugly fact. So it wasn't a single mutation that we saw. While we did see the gatekeeper in all 3 patients, we ended up seeing 5 different mutations in 2 of the patients and the gatekeeper in the 3rd patient. So these are ctDNA graphs where basically we looked at a series of FGFR2 clones. These are all mutations in the FGFR2 kinase domain. And we followed these clones over time using digital Doppler PCR. And you can see at baseline, none of these patients had FGFR2 mutations, but then over time, they emerged several mutations. So we wanted to understand this a little bit further. And so, one of the patients had 5 mutations in the blood, but when we did a tumor biopsy, she only had 1 mutation. So we wanted to understand this a little bit better. So her family was very kind and allowed us to do a autopsy when she passed. And so we all went in at 1 o'clock in the morning and did this autopsy. And what we found was that when we looked at 12 different lesions that we sampled, 4 of them had mutations in FGFR2, and 1 of them had actually 2 different FGFR2 mutations. But different lesions had different mutations, meaning there was a lot of heterogeneity between lesions, and even within a lesion, there was intratumoral heterogeneity, which meant that there were different areas of that metastasis that had different mutations. And so that's a pretty difficult problem to overcome. And so we started looking at what are ways to overcome this type of resistance. So there's another drug in the clinic called TAS-120. This is a covalent inhibitor, and basically it has activity against wild-type FGFR, but it also has activity against many of the mutations that we had identified in the patients who were on the first FGFR inhibitor. And as you can see, the other FGFR inhibitors do not have as much potency against these resistance mutations. So this is the unpublished work that we're about to put out. So we have 4 patients that first went onto an ATP competitive FGFR inhibitor. So they either went onto BGJ or they went onto WO1347. You can see all of them had a response to begin with, and then they all had progression. And then all of them went onto TAS-120, and this patient and this patient had a response. So 2 of the patients had a response, and then 2 of the other patients had stable disease. So all 4 had some degree of benefit on TAS-120. And so this is the ddPCR graph on just one of those patients. This is a patient who was on BGJ for 12 months. And as you can see, she had no FGFR2 mutations detectable at baseline, but as she started to progress on BGJ, she developed the FGFR2 K659M mutation and also the K714R mutation. And then she went on TAS-120. These both dropped in the blood. And then over time, she developed resistance to TAS-120. She was on TAS-120 for about 15 months. So we wanted to validate in the lab that these mutations were indeed resistance mutations. So we took a series of biliary tract cancer cell lines, and we treated them with BGJ398. And we found that 2 of them, CCLP and ICC137, were both exquisitely sensitive to BGJ with an IC50 of between 5 and 15. And this cell line, ICC137, was actually from the autopsy that we had done. So this one harbors an FGFR2 fusion, and this one actually has FGFR1 overexpression. We repeated the experiment with TAS-120. We found these same 2 cell lines were sensitive to FGFR inhibition, and the other ones were not. So then what we did was we infected them with retroviruses that were expressing the FGFR2 PHDDH fusion, and the fusion either had a wild-type kinase domain or it had one of the 9 mutations that we ended up seeing on the first 2 FGFR inhibitors. And then we sprinkled a little bit of BGJ398, WO1347, or TAS-120 on each of these different cell lines to check out their sensitivity to these drugs. And so we're basically trying to understand the spectrum of activity against each of these drugs, against the different resistance mutations. And just to orient you to how this graph is, each of these on the left is one of the mutations, and then this is the IC50, so the concentration of the drug that's required to inhibit 50% growth. And the more black there is, the less potent the drug is against that mutation. And so overall, what we found was that the mutations that conferred the greatest resistance to BGJ were mutations A, B, C, D, and then the mutations that conferred the greatest resistance to WO were A, B, C, but WO retained activity against the gatekeeper mutation, which was mutation D, let's say, V565F, compared to the other drugs. And TAS-120 was able to remain active against all the mutations, but was not able to maintain as much activity against the gatekeeper mutation. And so there are a lot of questions still to think about for IDH1 and FGFR resistance. So one that was one paper that looked at isoform switching, but is this a common mechanism of resistance to IDH1 inhibitors in cholangiocarcinoma, and what are we going to do when patients develop IDH2 mutations? What's the role of using ctDNA to evaluate acquired resistance, especially when biopsies may only capture 1 or 2 mutations, but ctDNA can capture 5, 6, 7 sometimes? Are there IDH and FGFR independent mechanisms of resistance? Are there non-genomic mechanisms of resistance that we need to be thinking about? What is the way to sequence FGFR inhibitors based on their spectrum activity? Are there FGFR2 specific therapies that don't cause hyperphosphatemia? And are there combination strategies that we should be thinking about? I think Dr. Hung's talk this morning about using the PKC inhibitors was very interesting, and so something to think about with these trials as well. So opportunities for collaboration between Asian and Western teams. I think it's great to think about collaboration between our teams in terms of working with pharmaceutical companies in genotype-directed drug development, because it's all about numbers, and so if we can have more numbers of patients, we can get these drugs approved faster. Thinking about non-genomic targets in cholangiocarcinoma, because we've been doing a lot of sequencing, and with genomic targets, we are able to isolate small subsets of patients, but maybe if we're able to go downstream a little bit, some of these pathways may converge, and we may be able to help more patients. And then lastly, trying to understand drug resistance and tumor heterogeneity as a group.
Thank you, Professor Goyal's wonderful talk. Any questions and comments?
Wonderful talk. Really nice overview of everything and the work that you guys are doing. So I had a question about primary versus secondary resistance, because I think you really touched beautifully on the difference that we see in lung cancer, for example. So have you guys looked at doing rapid autopsies on patients that have maybe even never gone on an FGF inhibitor or haven't gone on a second one, and seen if there's the same kind of heterogeneity that accounts for why 80% or not, or 60% are not responding to that therapy, or for IDH inhibitors as well?
Yeah, that's a great question. So we have done autopsies now on more than a dozen patients with cholangiocarcinoma. I would say none of them are treatment naive, understandably, because we normally do them after people have been on multiple therapies. From our understanding of the work that we've done so far, the FGFR2 fusion is an early event, so that is less heterogeneous. But the question about primary resistance as to why that's occurring, you're right, because we're only seeing a 25% response rate as opposed to a 70 to 80% response rate. Is it that patients have de novo existence of some of these alterations? That could be it, but they're probably in such low frequency that I don't think that's the whole answer. It could be that there are actually, these tumors are not fully dependent on FGFR signaling, or there could be co-upregulated pathways, such as the MAP kinase pathway, the PI3 kinase pathway. So both looking at acquired resistance and primary resistance are two things that we're very interested in. Great question.
You have a microphone next to you.
Thank you, Lipika. Very, very elegant. So just to continue that question, really, it's how, I mean, it's nice to hope that these cancers are single gene addicted cancers and that we can use one beautifully targeted drug to do it. But is that a mistake? Should we be using a pan-kinase inhibitor in the first instance? And, bearing in mind the issue about primary resistance, as you pointed out.
And when you say pan-kinase inhibitor, do you mean like pan-FGFR or pan like FGFR, EGFR, HER2?
Everything.
Everything. Well, that might be a slightly toxic drug, but I think that's a great idea. I do think that's why potentially, Dr. Hung's talk on using something that's a little bit further downstream, that all these tyrosine kinase inhibitors maybe all funnel down into one pathway at some level. I think thinking about that as a combination strategy with targeting upstream at the tyrosine kinase inhibitor level, I do think combinations will ultimately be the one of the ways that we can prolong benefit and delay resistance. The question is, what is the most efficacious and most tolerable combination? So we're doing some work in the lab to try to look at what downstream signaling occurs in cholangiocarcinoma. What we're finding is that it signals more through MAP kinase than through PI3 kinase, so a little bit different than some of the other tumors. But in other tumors, there have been some combinations with FGFR inhibitors that have been variably tolerated. So we'll have to see what ends up shaking out in cholangio. Yeah.
So Lippy, that was, as usual, a great talk. And I think it'll be a pity if we do not appreciate the fact that these mutations also reflect a different biology. We have discussed this before. FGFR fusions seem to reflect a different type of disease. And if there's a patient who might qualify for the type of surgeries Dr. Nagino mentioned, it could be like that, these type of patients who can have radical resections as well as metastatectomy. So I think it's a nice area for integration of multimodality therapies to look at, because it's more, I think, than just kinase inhibition, isn't it?
Yeah, I fully agree. In terms of being able to see responses, FGFR inhibitors, and then as we saw the BRAF-MEK data, we're actually seeing responses. So if it can be a neoadjuvant strategy for some patients, I think that would be fantastic.